well as we have a flat surface. So when we're doing measurements, guys, how important is it to be accurate?
Very important.
Very important, and let me tell you why. Because when the mom brings that baby for its 2-week visit, and it has shrunk, how do you explain that? Okay? It happens all the time. So how important is it to be accurate? Very important. Okay? Not only for your documentation now, but because I don't want to see this mom come to me and say, well, they said it was 21 inches and now it's only 19. Can you imagine how distressing that is? Babies may lose weight, but they don't lose inches. Okay? And I've seen it. So if you're not using proper technique, you're going to have a problem with your measurements. What I do is I actually mark the bed underneath the baby, move the baby out of the way, and measure my markings. Just make sure that it's not movable cloth, because I've seen that too. Okay? So you can do whatever you want, but the most important thing is that you measure properly. So one of the measurements we need is actually their length. And so what we do is we take and put the measurement, you're going to hold this, on top at the very tip, okay? So we're going to actually hold it there, okay? Because I need the top of the baby's head, okay? Now we're going to extend it and extend the legs. See how that baby just moved? Did you see that? That's what happens if you're not really careful. So again, you want to make sure, and you go all the way to the heel underneath and tell me how many inches this baby is. You pull a little bit towards me. Hold on, you pull them. Yeah. Yeah. Okay. So you get your friend's help. It's not easy. Do y'all see this?
So it's about 19 and
So 19 and a half inches.
Maurice.
Write it down for me.
Maurice.
19 and a half. So move. They
I'm
wanna
trying to see like
So
where
come
you're
on.
measuring to the heel. Like I'm
So
trying
you see how he's doing it, and he's pulling the baby's heel all the way down. You want to stretch that baby's heel. Now, what can happen that can make the baby seem like it's taller is if we have a little bit of a cone head. Okay? So we might lose a few inches. So we really want to make sure we're at the skull and not at the cone.
How do you
Y'all
do that?
with me? Does everybody know what I mean by cone head?
Yeah.
That's swelling, right. Especially in vaginal deliveries. So he's stretching and he's doing all the way to the heel. Okay, so 19 and a half.
Told you I would.
I'm right at the top
It's
of
in
the
front of me.
skull.
I'm gonna eat it.
Okay? Truly, what I do personally is I take a pin, I mark my bed here, I stretch their leg out, mark my bed, I move my baby out of the way, and I measure that.
Oh, yeah.
That's what I do. Right. Okay? So, that is our length. Let's say our baby was 7 pounds 5 ounces. So someone is going to convert that to grams for me because we have to have it in grams. Okay, 7 pounds, what did I say, 5 ounces? Okay? And now we need the head circumference. So how do we get a head circumference?
Measure around the
Again,
head.
guys, this is kind of tough when you have a cone head baby. Okay, so what you're really doing is you're going right above the baby's eyebrows. Okay? So you're taking it, you're putting it around the baby's eyebrows, and then you're pulling it the other side. And so it's right here. You don't have to go all the way because you're measuring it right here.
You're doubling up.
No, you're really giving them a big head. Poor mom. Poor mom. How many inches you got? 14. That's pretty average, between 12 to 14. Again, hopefully she had a C-section. A big kid, right? Okay, so 14. But we need centimeters.
That what blood
That
sugar
is
is
the
in there.
centimeters, right? Or was that inches?
You only need one piece of her candy.
All right, that's inches. So now we need to convert it to centimeters, and we have to convert that 21 to centimeters too. So tell me how many centimeters it is. This should be on here.
Multiply by 2.5.
I like my glasses. 36 centimeters.
I don't know.
So the head was 36 centimeters, and the length was, let's find our 19 and a half.
19 and a half.
So 48. Oh, 19 and a half right here. So 49 and a half. 49 and a half centimeters. Okay? You with me? Okay. So now what we need to do, thank you, you can go get your treat. So now what we need to do is we need to graph it. Okay? So it's 49 centimeters length. So you see the 49 on the left? And it was 38 weeks gestation. So you see the 38 at the bottom? So take the 38. It'd be easier if we had it in front of us, so I apologize. But take the 38, travel all the way up until it hits 49. And it is about the 70th percentile. Are y'all with me? About the 70th percentile on the baby's length. Okay? The weight converted to what? 34, 1.9. So let's take the 3,400. That's the closest. And you see the 38 on top. So take that down. 34 to the 38. And we're about the almost 90th, not quite 90th percentile. It's close. Okay, but it didn't go over. And then the head circumference was, help me remember, what did we say? 36. And you take that across, whoo, we're above the 90th percentile on the head. Right?
Maybe big head.
Okay, so we're above, we're large for gestational head, gestational age in the head circumference, but the other two are average for gestational age. The head circumference does not stand alone. Okay? The head circumference and the length do not stand alone. Now, if they were both above the 90th percentile, then they do. This baby would then be considered large for gestational age. The weight alone will make a baby large for gestational age. So if the baby was above the 90th percentile in the weight, but average in the length and the head circumference, it is a large for gestational age baby and at risk for what? Hypoglycemia and jaundice, hyperbilirubinemia. Okay? So are y'all with me? This is your Ballard exam.
So, so I had really small babies. They were both under 6 pounds, full term. And they both had jaundice, but no.
Okay, so there are other causes for jaundice,
Okay.
and we'll talk about that.
Okay.
Okay? Because I promised I would come back to Coombs, and we're going to talk about that now. I did remember. You were holding me to it, huh? So, when a baby is born, we draw cord blood. And is that baby's blood or mom's blood? Baby's blood. What are we drawing on the cord blood? What are important? What would be important to know about our baby?
I read this last night.
Not quite, because the CDC valid necessarily to utero. No, and we really don't need to know right away what their CBC is unless we're worried.
I was RH
Blood
positive.
type and RH and Coombs. Okay? Blood type, RH, and Coombs. This is when we're going to draw our Coombs test. Okay. Why do we need to know blood type and RH? Just in case mom's negative. Okay? But remember, let's go back to that AB or that blood type. So remember, if you have it, it's okay to see it. If you don't have it, you don't want it. That doesn't just go with the RH, it also goes with A and B. So sometimes in utero, if there's mixing of blood and mom's blood gets into baby's circulation and mom is A and baby's O, can you see a problem? And we call that ABO incompatibility. It's not a problem if the blood doesn't mix. And how often does the blood mix? Rarely. But if the blood does mix, we can have ABO incompatibility, okay? And so what's going to happen if the baby's O and mom was A and the blood saw each other? What's going to happen to the baby? Mom's blood is going to cause a reaction in the baby, which is going to do what? Destroy, break down red blood cells, right? What is bilirubin?
From the liver.
Broken down red blood cells. Bilirubin is the byproduct of broken down red blood cells in your body. And you only have a problem with broken down red blood cells when your body can't get rid of them or has way too much. Okay? So we're going to get back to that cord clamping delay because a baby is born with a lot of red blood cells normally because it has to have extra oxygen carrying capacity in utero because it's depending on mom, who might be a smoker, who might have other issues, who might not have good circulation to begin with. So it needs to grab as much oxygen and have as much oxygen carrying capacity as possible. Well, once it's born, it doesn't need them anymore. So a baby might have a hematocrit of 40-something, okay? High H&H. Then it doesn't need it. So it starts breaking it down within 24 hours, okay? So within 24 hours, we have all this bilirubin floating around. And how do we eliminate bilirubin in our system?
Like you
excrete it, poop and pee, okay? And remember that, especially a breast baby, it's quality, not quantity. And that breast milk doesn't come down for 3 days. So you think that baby's going to have a lot in to excrete? So guess who's more prone to hyperbilirubinemia? Breast babies. Okay? So how do we treat hyperbilirubinemia? Intake. Intake. The more in, the more out. Okay? But the problem is again, we don't want to discourage breastfeeding because that's important, but we need to just monitor it. And another way to also eliminate bilirubin is through indirect sunlight. And so we put them under lamps. Do y'all know how that was discovered? Like there was a nun who was working at a hospital who was taking care of these babies, and one of them just happened to be a hyperbilirubinemia baby, and she decided to take him out for some sunlight. And that's how we even discovered that, because where the baby was exposed, it was less yellow. Okay? So again, there's a level that a baby can tolerate before it can cause problems, because too much bilirubin does what to the baby?
Kills the liver, or
What is it?
it like
Goes toxic.
Causes what?
yellowing.
Liver failure.
It causes brain damage. If it's above 20, it attaches to the brain and causes permanent brain damage, also called kernicterus. You don't need to know that, but you may hear that term, kernicterus. And that is brain damage secondary to hyperbilirubinemia. So there's a fine line of comfort, and we need to do something before this baby has brain damage, okay? And so we need to make sure that we keep that bilirubin down. Treatment for hyperbilirubinemia is actually fluids, but we don't want it to be IV fluids. We really want it to be the GI tract. It eliminates a lot more bilirubin through the GI tract. What is a sign of hyperbilirubinemia?
Jaundice.
Jaundice. And so even though we use that term interchangeable, jaundice is really a symptom, okay? That's the yellow of the skin, and we know it's real severe when it's where? In the eyes, okay? So you're going to assess your baby for jaundice and making sure. But again, we know babies who are large for gestational age and small for gestational age are at risk for this, as well as other things. So if we have an ABO incompatibility, and what Coombs is, to get back to the question, I know you're waiting, like, what is it? That is the breakdown of bilirubin in utero, okay? So when we already have bilirubin present through this Coombs test, then we know this baby is going to have a problem. Like red blood cells have already started breaking down even when the baby needed it. So usually it's because of an ABO incompatibility or an RH incompatibility. But when a baby comes out positive for Coombs, we're going to be much more aggressive in treating. This baby's already going to start getting levels for bilirubin and probably be under the light quicker.
And that test comes from the cord blood too?
That comes from the cord blood. Okay? So when you're in the hospital, I want you to look for the Coombs test. In the nursery, it doesn't appear until 24 hours. So you're really going to find that with your postpartum patient, because I think most hospitals still do mother-baby care. So you can still get the information from the baby in postpartum. But I want y'all to look for that Coombs test and see if your baby's positive for Coombs. Okay? Any questions on that? Now, we need to talk about the newborn assessment and what's important for the newborn assessment. When we're doing a newborn assessment, what are we looking for in the assessment? You know, we've talked about the ACPAR, we've talked about the Ballard. Both of them are very important tests that we do, very important assessments, but we haven't really talked about the newborn assessment and what we're looking for. So it's pretty much head to toe, but we're trying to figure out if there's any abnormalities. So some of the things so I'm going to just kind of go over some of the main things you might see when you're looking for abnormalities, instead of going through the entire head-to-toe assessment. But guys, you need to know how to do a head-to-toe assessment on a newborn, okay? Even though you're not doing it in clinical, on paper, please make sure you know how to do it, either with a nurse or with your instructor, okay? So besides all of that, we're checking for reflexes. So I'm going to pull up reflexes so we can go over those. And then we're going to go back to like the head-to-toe assessment and findings we need to be checking for. So what are For a video. Let me see if I can figure out which one this is. Okay, so here's your primitive reflexes that should be present at birth, and if they're not, then it could be a problem. So, the startle or Morrow reflex, sometimes they're separated, okay? But the startle reflex is that the baby startles. So you're gonna see that your nurse might actually lift the baby up and drop, okay? And the baby should react. That's the startle. The Morrow is the position the baby assumes. So again, sometimes you'll see them put together. Sometimes you'll see them separate. But the Morrow is the position they assume. The startle is that the baby reacted. Okay? Rooting reflex we talked about yesterday. That's where you just press the side of the baby's cheek, and it should turn to that side. Isn't that amazing? Like, what is that for? For breastfeeding. So you put the baby up to the breast, and then you just stroke the baby's cheek, and it should turn towards that side. Okay? So that's the rooting reflex. The sucking reflex is actually you put your tongue in the you put your finger in the baby's mouth, and you kind of massage the palate, and it should suck. Okay? Some babies, especially if they're immature, are not going to have a suck reflex. Are they going to have a hard time breastfeeding? Yeah. Is this an important reflex we need to make sure the baby has before we put him to the breast? Yes. The grasp reflex is if you actually put your finger in the baby's hand, it will wrap its fingers around your finger. Okay? That's the grasp reflex. I'm not even sure what that is. But the tongue thrust, I like the other one better. Let me flip this out. They probably are calling it something else. So, but the tongue thrust is actually the baby will do that as part of its almost rooting for sucking.
You can have mine for me.
It's not really something we do.
Lord. There's a Brady Bunch over here.
Okay. So, this even talks about when these reflexes go away. So your startle and Morrow goes away about 6 weeks of age. Your rooting usually goes away around 4 months, 3 to 4 months of age. Suck reflex lasts until they're about 2 to 4 months old. Okay, Babinski.
Sorry.
The only time you want your baby to be, the only time you want anybody to ever be positive Babinski is at birth, right? So your Babinski is just like in adults. Who remembers the Babinski? Okay, you actually rub the side of the foot from the heel up. When you stimulate it, the toes flare. Okay? So the toes flare in response to that. In an adult, is that a good finding? No, it means that they're neurologically impaired. But in a baby, we anticipate it. We want it to be there. When does it go away, you think? Before they walk. Okay? That's all you have to remember. So by the time they're 9 months to a year, it better be gone. Because you can't walk with a positive Babinski, right? Okay. So it's going to be gone then, and you never want to see it again. The walking or step reflex, actually, if you place the baby, supporting them, you place the baby upright, and you touch their feet to the bed, one foot will come up. Okay? That's the step reflex. You keep doing it, the other foot will, one will go down, the other foot will come up. Okay? So that's the step reflex. Usually goes away around 2 to 4 months. Or 4 to 6 months it says, but your grasp, we talked about that already. Okay. And the only other one is you do have a plantar grasp. Okay? You have a palmar grasp and a plantar grasp. So grasp. And so if I take my finger and place it right below the baby's toes, they're going to wrap their toes around my finger. Okay? So some of the other things we need to include in our assessment is we have to make sure our baby has eyes. I've known babies to be born without eyes.
What?
They have eyelids and no eyes. We want to make sure that their ears are normally formed without skin tags. And what does it mean if you find a skin tag on their ear?
What is a skin tag?
A skin tag is just a piece of skin,
Like an extra piece of skin.
just an extra piece of skin. So that means during the development of the ear that something went wrong. Usually it goes in tubes. So what internal organ looks like the ear? The kidney. Guess what? They developed at the same time. So what are you going to anticipate the doctor's going to order when you call and say, my baby has a skin tag on their ear? A kidney ultrasound. They go hand in hand. Chances are, especially if it's significant, they have a kidney problem. Interesting, huh? Isn't that amazing? Like the kidney looks like the ear and they developed at the same time. So we're obviously listening for any heart murmurs. Is it abnormal to have a heart murmur at birth?
No.
No.
No. We're looking at the cord at the vessels. There should be 3 vessels, okay? In utero, and I don't go into depth into this, but for your own knowledge, I would make sure you understand circulation in utero because we're not using the lungs. So guess what? Circulation in the baby is the opposite. So arteries carry what in our body?
Oxygen.
Oxygen. And veins deoxygenated. It's the opposite in a baby because the oxygen is coming from mom. So it's actually being carried in by a vein and out by arteries.
So when does that change?
Right when they're born. So circulate,
Automatically?
it automatic. So can you see what could go wrong if it doesn't happen? So the heart valves, the heart arteries and veins have reroutes in a baby to divert the blood from the lungs because it doesn't need it, okay? And so all of that right at birth has to switch. So can you see why a newborn might have some problems right after birth in that swap? So
Makes sense. That's
it's
one of
not
the
an
ones
abnormal
between the
finding to actually have some heart murmurs because it doesn't happen for some babies right away, and sometimes we have to give medication to make it happen. So is your assessment important? Absolutely, because your doctor may not be there for 24 hours. Because he has 24 hours to make rounds on that new baby.
So if we hear a murmur, the first thing we need to think is
That either
switch hasn't
PDA
happened.
or right, something has not closed. And again, I'm not going to go into detail because it's much more than you need to know. But there's 2 areas in the heart, heart arteries from the heart that are open normally in utero and they close and die off after you're born. Okay?
You don't need them no more.
Because you don't need them anymore. Okay? And then the same thing happens with the liver circulation and how it's diverted. So for your own information, I would review that. I'm not going to test you on it, and it's way more than you need to know. But just know it's the opposite. But we need to make sure that this baby had the arteries and veins, and if something was missing, we need to know why or what. So, we have 2 arms and 1 vagina. So you have 2 arteries and 1 vein. Okay? So you should see 3 vessels. The arteries are much smaller and the vein is very large. Okay? So remember that. And now you know how to remember how many you have.
You can say that again.
Do you really know?
You don't have to say the vagina.
2 arms, 1
2
vagina.
arms, 1 vagina.
And-
So
and it
2 arteries,
represents-
1 vein.
Okay.
Okay? And so when you see, now you need to look, because if your baby is missing one, do you think there might be a cardiac issue?
You can see that.
Because in the development, something went wrong.
You can see that on the umbilical cord.
Yes, you're going to actually look, and afterwards you can come and look. There's actually 2 arteries and 1
Oh, wow.
vein.
And the veins are going to be bigger than the
The
arteries.
vein's bigger than the arteries because the vein carries the oxygen.
Wow.
Okay? Y'all with me? Very good. So we need to identify that on the baby. We do an abdominal circumference, which we didn't do before, but we're actually just checking the abdomen and measuring right at the umbilicus. And why do we do that? Because if our baby has abdominal distension 24 hours from now, we have at least what it started with. Okay? Because it can identify some GI issues. We need to look in the baby's mouth and look at the palate to make sure the palate's formed. We need to make sure there's no teeth. Yes, babies are sometimes born with teeth. And can you see how that could be an aspiration problem? Yes. Because they're usually not good teeth and they usually do fall off and can then cause choking. And so usually you'll have to get a dentist to come in and take them out. We're looking to make sure there's nothing abnormal. Okay? What are abnormal things you might find? Or Epstein pearls on the gum line. Again, anything abnormal. Our baby with shoulder dystocia, we're looking for clavicle fractures. Okay, so we're checking for crepitus here. What's another indication of a clavicle fracture? One arm's moving and one arm's not. If a baby's favoring one arm, you then really need to identify and let the doctor know. So we're checking for abdominal sounds. Babies breathe with their abdomen. They're abdominal breathers. So when you're checking for breathing, you're really looking at the abdomen or listening to the lungs. It's very difficult to listen and hear breathing because they're usually crying. Okay, so keep that in mind, and it does take some time. It is not an abnormal finding to have wet lung sounds for 24 hours after a C-section. So it is not abnormal for your baby to have moist lung sounds 24 hours after. We're checking vowel sounds, we're checking movement. We're checking for hip dysplasia, okay, or hip problems. So we're doing an ortolani's, which is where you take the legs up and out and feeling for a hip click. You can imagine that some babies might have some hip problems, right? Because they've been squashed in this big, small space. And so we're checking an ortolani's. Okay, and I actually have a good picture of that, so I'm going to show you. So ortolani's is where you push up and out, and you see where his fingers are? They're actually on the hip, because that's where you're gonna feel the click. And then a Barlow's is actually, if you hear that click, you need to put it back in place. So you're actually, and you wouldn't be doing a Barlow's, okay? You would be doing an ortolani's to check for hip dysplasia, okay, in the newborn. You're gonna get how to draw blood on a newborn in the rodeo. However, we need to know what type of blood and why you would be drawing blood on a newborn. Is it an abnormal finding to have an elevation in white blood cells 24 hours after the baby's born?
No.
No. You might have a slight elevation. What if you have a low temperature on the baby?
That's not good.
It's what? And it could be an indication of what? Infection. Okay, so low temperature on the baby, temperature is so important. You want to know your normals for heart rate and respiration. But a low temperature, obviously, we worry most about. We want the baby to be 98.6 axillary. We only do axillary temperatures. Some hospitals may still be doing their first temperature rectally. Most of them have gotten away from that. I'm trying to think what else we need to cover. So let's talk about PKU. PKU is phenylketoproteinuria. Okay? Every baby gets a PKU done. And what we are testing for is the presence of a genetic disorder of people who cannot digest protein. You can see that that's a problem, right? So these people who cannot digest protein actually have a buildup, and it can cause brain damage. But we know that we can stop that brain damage by identifying babies who are at risk and actually giving them special formula. So if a baby is found to have PKU, then they have a lifetime supply of formula, well, through childhood, and they're on a very strict diet for the rest of their life. We can't cure it, it's a genetic disorder. And so every baby is tested for PKU. However, in certain states, there are other tests that are latched on to the PKU. You don't have to know those tests, but just know that your state, when you're doing a PKU, might also be testing for other things. I know, because I haven't checked in Mississippi, that in Louisiana there were 11 different diseases that they tested for, one of which was more prominent in southern states being sickle cell. So in the state of Louisiana, sickle cell happens to be something that we test for. Now, if it is a digestive problem of protein, is the timing of the test important? Because what must the baby do before we test them? Eat. So we have to wait at least 24 hours after they have eaten. Otherwise, it's not a good test. And what ends up happening if somebody is identified as a risk, they retest them again. So it's not just automatic, but they retest them again. Okay. So we normally do that. It has to be 24 hours after they're delivered and have eaten. But normally we do it before discharge. Every baby will get it. You do need to know what a PKU test is. Okay? Tomorrow they'll go over how we test babies, but essentially, what is the place on a newborn that we do for blood that is not a blood draw? We don't go, and I want you to know, we don't go testing babies for nothing. even an AccuCheck, there has to be a reason for us to do it. And one of those things we identify is that large for gestational age or small for gestational age. So we're gonna, your baby comes out small for gestational age, you're gonna anticipate doing what? An AccuCheck, right? So that's how we identify it. So we don't go around drawing blood on every baby. And even the AccuCheck, we're not gonna do from a vein, we're gonna do it from what? Where do we get blood from a baby? The heel, okay? The heel, and it's usually the outer aspect of the heel. That's where you wanna get it, okay? Sometimes we can go inner, but you're never gonna go up, okay? Why don't we go to the center? So truly, we could have caused nerve damage, but the most important thing is it's closer to a bone. So we don't want to possibly expose the baby to infection, okay? So we're going to reduce the exposure. That's why when we do an AccuCheck on a patient, we go on the outside and not in the center, right? You thought you're just doing it because it hurt there. Y'all didn't know there was really another reason for it. Y'all are so nice. Okay, so that's why. I'm trying to think of anything else. We do want to make sure that there's not any other birth traumas and that such. Let's take 5 minutes, then I can make